let me just say, got it. Yes, so first things first, maybe I should make a disclaimer about most of the images I'm going to use. They are all borrowed images, most of them are borrowed images. And you will notice that maybe I've not acknowledged the source of the images. You forgive me for that. But some of them are my images, which if anyone wants to use them afterwards, they are free to do so, because they're my images. And it's actually my first time to present on a forum like this. So if there are hiccups, if I start stammering or something, you bear with me, because it is my first time. And I pray that our internet won't act up. So without wasting much time, let's get to the presentation. So this presentation is inspired by my own injury. Remember in January, some of you might have noticed that I once shared some of my images on our ultrasound platform when I ruptured my Achilles tendon. So during the course of my discussions with Mr. Chimfembe, when we were trying to get some presentations, I was trying to talk to a radiologist, my radiologist, to share with us something. Then he's the one who encouraged me, like, I can't be the one presenting when you are the patient with a case. So let's share your case with your colleagues, because it was a case that we followed as a department, the challenges we had, and how the modalities we used on you. So those are the things you could share with your colleagues. So this is how we got to this case presentation today. So this is how I intend to have the presentation. If we have basic anatomy of the Achilles tendon, Achilles tendinopathy, imaging of the Achilles tendon, management of Achilles tendinopathy, then I'll share with you my personal experiences, then maybe we can discuss together at the end. So there's quite a lot of information or literature review that I got from the net. Maybe you can still come across it when you are reading further, but still I thought we could share it here so that we understand the anatomy of the Achilles tendon. The diagrams are here. So the normal Achilles tendon is composed of 3 twisted subtendons, 2 from the medial and lateral heads of the gastrocnemius muscle and 1 from the psoas muscle. So this is the medial gastrocnemius and this is the lateral gastrocnemius muscle. Then we have the psoas muscle here. So our Achilles tendon will originate from there, going down to join with the calcaneus bone. So basically, it's the job of the Achilles tendon is to join the lower limb, the leg, basically with the ankle joint. And so it's going to be responsible for the movements of your foot. So the flexion and the balancing and all the things that we need to do with our legs concerning the foot, mostly the Achilles tendon is involved. So minimize this. It is enclosed almost entirely within a paratendon. The paratendon has both visceral and parietal layers. The insertion site of the Achilles onto the calcaneus is in enthesis and is intimately related to the only true anatomic bursa in the ankle, the retrocalcaneal bursa. So this is the retrocalcaneal bursa. I think we have a better picture here. This is our calcaneum, our retrocalcaneum PSI is somewhere here. This is where it will insert into the calcaneum. So the Achilles tendon is approximately 15 centimeters in length. It is said to be the strongest, largest, and thickest tendon on the human body. It is made of fasces with the interfascicular membrane separating the fascicles into bundles. So you discover that this is just the micro appearance of the tendon. If you go down to microscopic, it will have fibroblasts, and these are actually elastic, which allows it it's actually an elastic tendon. So when you are walking or doing any action with your foot, it actually stretches. So before it can break, it would have stretched for some distance, but then for other reasons that we'll discover later, it may easily break. So the normal average thickness of the Achilles tendon is about 6 millimeters. Other books will say 8 millimeters. So this will actually depend on gender. Males having a thicker Achilles, the females having a less wider one, and tall people have thicker Achilles as well. And as you get older, it also gets thicker. So there are two types of Achilles tendinopathy that we have. That's incisional and mid portion. Incisional occurs within 2 centimeters within the insertion of the Achilles in the calcaneal bone. Just distal to the Achilles, but close to the calcaneal bone. That's the incisional one. Then the mid portion occurs more proximal, which is like 2 to 6 centimeters from the distal point from the calcaneal bone. Achilles tendinopathy involves damage, swelling, inflammation, and reduced function of the Achilles. So I'm just going through the literature review that we all can find everywhere. So the risk factors for tendinopathy include sports that stress the Achilles, e.g. those in my case that we're going to discuss today, it was Sunday soccer, which is on the second point there, which says a significant relationship between leisure athletic activities and tendon injuries exists. So you discover that most of us are not really sports people, but once in a while when an opportunity arises to do some sporting activity, we want to outdo ourselves and perform like we are regular sports people. So when we do that, because our tendons, especially the Achilles, will not be accustomed or used to that kind of quick actions, they will easily rupture. So maybe when we finish the discussion, that will be one lesson that we should take, that we need to exercise regularly ourselves. Let's not just find ourselves on a single excitement day to want to outdo ourselves and outdo others when you have not been participating in any physical activities during any other times. So the other risk factor is when you get old. In my case, I have reached my 40s. I should think this applies to me as well, because the average, they say, literature that I came across says on average 36 years is the average age where we have these most injuries of the Achilles tendon. So once you get to 36 and cross 40, you are at great risk. Literature says that almost zero injury to Achilles tendon in adolescence. So as we get old, we need to take it easy. So The other issue is family history. Those, if it may run in the family. There's some also antibiotics that, like that fluoroquinolone, it predisposes people to tendonitis. So they advise that if you are taking that drug, the fluoroquinolone, if you just get any sign of inflammation of the Achilles tendon, you should actually stop immediately, because it's almost given that if you continue, you may end up with Achilles rupture or tendonitis, as well as systematic steroids there. If we have the anatomy, we can move on to the imaging of the Achilles tendon. So basically, the Achilles can be imaged in the radiology department by all the modalities that we have, including CT that I did not put there. MRI is the most superior one, followed by ultrasound, but there are instances where ultrasound shows much better than MRI. I think on another slide we'll get to that point again. So where the MRI and ultrasound are not there, we can still do a lateral ankle radiograph, the conventional ankle joint. It may help to show the Achilles injury. Let's look at MRI. MRI is most superior to ultrasound in detection of partial tears and for post-operative assessment. The use of fat suppression sequences allows the ability to detect focal lesions. Sagittal and coronal sections are useful for assessing the distance between stumps of a ruptured tendon. So this actually is an important point. This assessment of distance between stumps, because when you rupture your Achilles, and if you don't get help on time, the stumps, if it's a total rupture, the stumps will separate and move far away from each other. And as we will see when we get to the management of Achilles, ruptured Achilles, if they have to do, in fact, if the stumps move far away from each other, then it means the only treatment will have to be surgery. And if they have to do surgery, and if the stumps are far away, they will have to hunt for them, and to get them back together again will be hard work for the surgeon, and to result in a prolonged healing period. So before the surgeon can open, sometimes they need to know the distance between the stumps of a ruptured tendon. We'll still get back to this later. Sequences with contrast are indicated in post-operative investigations and suspicion of infection, arthritis, or tumor. MRI may also reveal inflammatory changes with minor symptoms long before the clinical manifestations of seronegative spondyloarthropathy. So if you have any symptoms of tendonitis and you do MRI, MRI can actually help to pick up those changes that are happening to the tendon, to the Achilles tendon in this case, and then that could be helpful to prevent further damage to the tendon. If we know that there are changes that are happening, maybe you are getting it's inflamed or there's some calcification taking place, then management can actually start much earlier before we get to rupturing. Ultrasound of tendons. I think I was thinking that say Cuthbert has dealt a lot with the MSK here, And we are so grateful to that. So like any other tendon that he has discussed, the ultrasound of MSK is applies as well to the Achilles tendon. So MSK ultrasound is frequently used for assessment of tendonitis. The usual advantages that we have is that it's readily available, is a relative quick scan time, it's got better patient ability compared to MRI, where some patients do not tolerate that country. Also, with ultrasound, you can scan both Achilles tendons for comparison. It's much faster and easier. Then, well, the other advantage being that you are actually interacting with your patient there and then, and you can actually custom or tailor make your study to that particular patient. Put them in the position that's most comfortable for them, which you can do maybe when you are using MRI. Tendons should be interrogated, scanned along both long and short axis, orienting the ultrasound probe so that the ultrasonic waves reach the tendon perpendicularly. I think this one, when we finally look at some images, we'll get the importance of this. And I remember when we were taught about the MSK of the shoulder here, it was emphasized this perpendicularity of our wave. Because if you scan tendons at an angle, you actually get a totally different image in terms of echogenicity. And if your echogenicity changes, you are likely to see pathology where there probably is no pathology because of the angle that your beam will strike the tendon. So you have to scan at a perpendicular direction to the tendon. The highly ordered pattern of collagen tendon fibers shows the highest echogenicity when examined perpendicular to the ultrasound beam. If this is not the case, the majority of the reflected ultrasonic waves will not be received by the transducer and the tendons will appear hypoechoic or anechoic. We'll see this when we get to the images. So we remember this artifact, anisotropy, which is a result of scanning at an angle which is not perpendicular to the tendon. So on image A, this is, you see that within those arrowheads, that's our tendon, a transverse image. That's nicely hyperechoic, and you can see the fibers nicely. It's almost homogeneous. When you go to image B, you will discover that now, if this is the same patient scanned at the same time, but just by changing the angle of the probe. Now, when you change the angle of the probe, the image changes. It becomes hypoechoic and almost heterogeneous. So if you were to rely on image B, you would say there's pathology on this tendon. But if you place your probe properly and avoid the anisotropy artifact, you will get a homogeneous, nice hypoechoic image, which will show you that there's no pathology with this tendon. So the challenge that you are going to get when you're going to scan tendons is that most tendons are tortuous. They are not really straight. So for you to get the whole tendon at a perpendicular angle, it's very difficult. But when it comes to the Achilles, it's a relatively straight tendon. So it's very relatively easy to get proper images without the artifacts. All you need to do when you get now close distally to the calcaneum. That's where it's going to cave. Then you also follow it with your probe where it caves medially. You also turn your probe so that you remain at 90 degrees. Otherwise, if you don't do that, you are going to say the Achilles on its greater length is normal, but maybe there is a pathology when you get to the incision at the calcaneum. On our screen, we have a conventional radiograph, which I was saying where there's no ultrasound and where there's no MRI. When a patient presents, a radiograph can still be taken. It can provide useful information. The only trick when you have to do a radiograph is that you have to do a high contrast image that will show both bone and soft tissue. If you overexpose, then definitely you are not going to see your tendon. You are not going to see your fat pads. So these arrowheads here on this image on the left, they actually show the Achilles tendon, which is continuous and smooth and attaching to the retrocalcaneum. And you can actually tell that it's smooth and straight. When we get to the image on the right, what we are picking here is that now this Achilles tendon is now, if you compare the size from here to there and this one from there to there, you can see that this one is enlarged, for lack of a better word, which means there must be pathology. Something must be. It's It's actually, it matters. So this is pathology, and this is the normal Achilles tendon, which is not enlarged. So I have to emphasize again on, if you are going to use the conventional radiography, then you have to make sure your exposures are good and do a lateral. Otherwise, an AP will not be of much help in this case. Let's get to the management. So when a patient presents maybe an emergency with suspected Achilles injury, it's an orthopedic review. It's very important that management starts early, almost immediately. What they do there is, the first thing is to immobilize the ankle, rest it and immobilize it, apply some ice to take care of edema, elevate it, take care of edema and give some painkillers. And then the next thing, what you want to ensure or check is whether the injury, is the Achilles ruptured, or if it's ruptured, is it partial, is it complete, or is it just maybe inflammation that's there, or is it any other injury that is there? So once that is verified, which will go back now to our imaging modalities. But as we get to the discussion later on at the end of the presentation, we'll discuss whether these modalities are really necessary, or this should be a clinical diagnosis in ER. So if it's if the Achilles is ruptured, now the surgeon need to decide whether to go the surgical way or the non-surgical way. So the non-surgical way, of course, is preferable if the stumps have not really separated, they're still close together. If the stumps are close together, then they can provide a boot with the ankle in extension for some weeks, and then maybe after 6 weeks they change, then give you another boot that is in a normal position for the ankle. If you have to go the surgical way, like in my case, when we look at it, because mine was over 95% rupture, so the surgeon decided we should go in a surgical way. They say the surgical way, there is greater chance of non-recurrence of the rupture. Yet, if you go non-surgical, it may heal, but it will be susceptible to rupturing again. But if you go the surgical way, after the surgery has been done, the management after that is the same as the non-surgical. You still get the same boots, the one with the knee extended. Then after some 6 weeks, then they change the boot to the normal position. Again, you do another 6 weeks or so. But after that, you need a lot of physiotherapy when the Achilles is healed, for it to regain its functionality like it was working before. Otherwise, you continue limping. In my case, I'm almost healed, except that there's a low pain on the wound, on the suture line when it's a bit cold, but I still cannot walk straight. Yeah, so I'm undergoing physiotherapy at the moment to try and get back my normal walking step without the limp that I have now. Okay, so on our screen, this is the scan that was done on me, but this one was done after, this was after, I think on the 2nd week. So what we see there is that there was the rupture, but what I suspect we also have here must be a hematoma. I don't know, maybe when we discuss these images later, we can, somebody can review and tell us maybe if that's not a hematoma, but I suspect I had developed a hematoma here. So this is the site of the rupture on the right Achilles. This is the longitudinal view, and this is the transverse view. So I also had the privilege of the MRI, but I didn't put too many of the images. But if you look at the MRI, you can see the site of the injury here. I thought I got the same. This is the same area of the injury, or almost the same cuts on this image here. So on the MRI, when almost on all the windows, you will see that your tendon will be hypercoic, if I should use that word, on almost all your images. So the dilemma we had here initially was, okay, so if you're going to decide to to go the surgical way or the non-surgical way, are our stumps still close together? Is this a complete rupture? Do we need to open and bring them together, or do we need just to go non-surgical, give a boot and allow them to allow the Achilles to heal on its own? As we'll see on the report later, I put the report here. My radiologist wrote that it was an acute partial tear. So normally, if your radiologist goes on an acute partial tear, then the non-surgical route could be the best route. But when the orthopedic surgeon looked at the same images, he was convinced that we had a total tear, and the best route to go was the surgical route. In any case, I agreed on the surgical route. I thought since they're saying when you go the surgical route, there is less chances of re-rupturing again. So since I don't want to re-rupture, I said, let's do the surgical way. Yeah, just some image to scare you when I was in theater. So, but he tells me that here, there was 1 or 2 fibers that were still holding when they opened, but they managed to bring they found the other stump this side and brought it together, and hopefully I will heal and not rupture again. So maybe let me keep it short and bring us to the end of this discussion by asking whether we really need to do all these things when it comes to Achilles injury. Do you need to do MRI? Do you need to do ultrasound? Do you need to do the X-ray? Or this should be strictly in a clinical diagnosis that doctors in the area should pick up and manage without any imaging modalities? Is doing imaging a waste of money? Is it a waste of time? Would the management change because of the modalities that we have used, or without us, management can still go on perfectly? I hope I wasn't talking alone, because I haven't had anyone even cough. Maybe let me stop here and open up the discussion.
Their mics were muted.
Thank you so much, Mr. Tambeyi.